Good morning. My name is William Porter McRoberts, MD. I'm an interventional spine doc, a interventional physiatrist here in Fort Lauderdale. Today I want to talk to you about spinal stenosis, what it is, what the current treatments are, and what are the options for people who have spinal stenosis. So today I'm just basically going to have a clinic visit with you as the patient. Presumably you've either heard of or been diagnosed with spinal stenosis. The first thing to understand is what it is. It is a disease of the spine where the canal narrows because of settling over time, and that settling essentially comes and pinches the nerve roots. I'm going to show you some MRIs. I'm going to show you how to read an MRI. I'm going to explain how it works in the pathophysiology, why people hurt and why people have this problem over the next few minutes. Spinal stenosis really only affects older folks, and virtually everybody, if you've been around a little while, knows that people settle and they lose height. My own dad has lost a couple inches, even though he's had no back pain. It's because the discs settle over time. It's commensurate to living on a planet with gravity. It's kind of like wrinkles. It just happens. But the problem is those discs have no place to go as they settle, and the ligaments surrounding the discs and also in the back part of the spine have no place to go but in. And the in that they go is inside the actual canal. And you can see the canal here. It's a bony, rigid hole, tube, so to speak, that houses the spinal cord and the nerve roots. And as the lumbar spine settles, those ligaments move into the canal and compete for space with the descending nerve roots that go to your buttocks and legs. And so the hallmark symptoms of this problem are that folks have low back, buttock, and leg tiredness, weakness, or pain with walking. And this problem is generally relieved or made better when folks sit down, and it's just the neuroanatomy. The spine, when we walk and stand, develops an increased lordosis or curvature. And that curvature of the spine actually accentuates and increases the infolding of the ligaments competing for space with the nerve roots. And that's why those nerve roots and your leg and your buttock seems to cramp or hurt when you stand and walk, because that curve accentuates the infolding of the ligament and competes with space. As you sit, however, what happens is the femurs come forward, it bends the sacrum back, and it opens up the canal, and then those nerve roots can breathe. So this is a very common problem. It's approximately 800,000 Americans a year are diagnosed with this. It's about equal to knee arthritis and hip arthritis, maybe a little more prevalent. And essentially everyone's going to get it at some point in their life if they continue to stay on the planet and age. And it's become a real issue. And sadly, the only thing that we had for many years was a big open surgery called a laminectomy, and then consequently a fusion. And so we were for many years faced with a decision, either to perform a big operation on the low back, this open laminectomy and fusion, or simply live with it and maybe have some epidurals or shots in and around those nerve roots, put a little steroid to see if we can reduce the pressure on the nerves. Sadly, those injections have not been shown to be super efficacious over a protracted period of time. Some folks, around 30% of people, get meaningful relief, but the remaining 70% simply don't get long-term relief. And so those folks are left with essentially a big surgical decision. Physical therapy is one of the things we've tried in the past as well, and the only type of physical therapy that really works is physical therapy that works on strengthening the abdominal musculature so that it maintains the flatness of the spine as you stand and walk. But that's difficult, and over the many years I've been in practice and tens of thousands of people I've seen with spinal stenosis, I've only had a couple people get long-term meaningful relief with physical therapy. Those two folks, interestingly, were both doctors who took it upon themselves to do sit-ups to the cows come home, or crunches rather, and strengthen those abdominal muscles so it changed the actual angle of their spine. And they were both successful. But virtually everyone else I've ever seen has not been able to do that. So The great problem is that as people have this disease and it progresses, their walking tolerance and distance diminishes immensely. And as Hippocrates said, walking is the supreme medicine. And if you can't walk, then everything deteriorates. You get cardiovascular disease, you get osteoporosis, depression, can't get around, can't go see the grandkids, you can't take care of yourself. Everything goes down. And the ability to care for yourself and to maintain your health is essentially dependent on walking. And as that distance and tolerance drops, the rest of your animal suffers. So why does it happen? It happens because the discs settle over time. Who does it happen to? It happens to everybody. There's no getting out of this life without being essentially exposed to some spinal stenosis. Some folks are born with a larger central canal, and they're less likely to have it. It's just the luck of the draw. Some people are more petite, or their canal is a little more narrow congenitally, and they're at a higher likelihood of having this issue. The symptoms are essentially a function of the compression of the nerves. We know that the perfusion pressure of these last tiny little arteries, arterioles we call them, that perfuse the nerves, is about 30 to 35 millimeters of mercury. So if you think about your blood pressure, 120 over 80, of course, you've got perfect blood pressure. That pressure is at the heart. And as the blood then is distributed into the peripheral vasculature, into the arteries that get first the aorta and then the bifurcation and thus smaller and smaller arteries, that pressure drops. And at a certain point, that pressure, where in the smallest arteries, the arterioles, deliver oxygen to the tissue and then pass the blood on to the veins, you need about 30 millimeters of mercury to get that blood through. So you can do a quick test. If you push your finger on your skin, and if you blanch the skin, you're overcoming that perfusion pressure. And that's what's actually happening in your spinal canal with these nerve roots that are inside the canal. The ligament is pressing on those nerves and it's overcoming the perfusion pressure, and the blood is not getting through to the nerves, and you get ischemia or loss of blood flow and oxygen delivery to the nerves. And that's why you feel the cramping and pain in the areas that those nerves serve, which is generally your buttocks and legs and feet, possibly calves, commonly, back of thighs. As you sit down, you change the anatomy. The spine's a mobile substrate. So as you sit, it moves, it changes position, and the ligaments are pulled off of the canal, off the nerves, and all of a sudden those arteries are allowed to perfuse those nerves, and the feeling returns, and the claudication, we call it, goes away. I would say spinal stenosis is a disease of millimeters. 1 millimeter more of compression and significant symptoms exist. 1 millimeter less, and sometimes one's asymptomatic. And we know this because the position can change, and the implications for the spinal anatomy are significant. Sitting is dramatically better than standing and walking. And the greater that difference, the greater the disease process, and also sadly the likelihood, or happily the likelihood, for a good outcome with some of these minimally invasive procedures that we're going to talk about. So how do we look at the MRI? I'm going to explain the MRI here, and I want you to just follow it through. You can open up your own MRI and have a look and read it just like the radiologist does, and have a look at it. So here we go. Okay, so here we are looking at an MRI, and I'll have to explain just essentially how we look at the MRI. These are two images. The one on the left is what we call a sagittal cut, and this is an axial cut. And the first thing that we notice is that this all looks foreign to most people, so we got to understand this is, imagine a person sitting and facing to the left side, and this is the skin of their back. This slice goes right down through the actual middle of their back. And so we can see this little purple scout line that shows us where this slice is. And as I say, MRIs are really a digital autopsy. We get to open up the patient and look inside and see the anatomy without ever using a knife, thank goodness. And so to understand what we're looking at, the way the spine is formed is we have the skin here, subcutaneous tissues, and we're essentially going deeper and more towards the stomach and guts, which are out here. And you see these next are the bony spinous processes. You can see them there, the ligaments in between. And then inside the canal, inside the tube, is essentially two things. We see cerebral spinal fluid, which is the light white, and then the dark gray is the spinal cord and the nerve roots. If we go more to the front, more anterior, we see the bones separated by disc, bone, disc, bone, disc, and that comes all the way down to the sacrum. So this is the base of your buttock. If I were to put my finger right here on someone's back, it'd be right at the top of their cleft of their buttock. And then this would be about the base of their ribs, right up about maybe about 6 or 8 inches up someone's back. So we see disc, bone, disc, bone, disc, bone, and then we see aorta, vena cava, and all the guts out front. So the first thing we notice, I'll show you what a normal disc looks like. This is a normal disc. What's normal? This is a 88-year-old patient of mine. This disc right here is tall, plump, and juicy, which is more like a 45 or a 50-year-old disc. These three look wonderful. There's minimal posterior bulging. There's a little bit in the front. And you can see that as a result of this tall disc, the canal is additionally open and capacious. As we come down, we see this disc is significantly different from this one. It's lost its height. There's a bulge in the back, and that bulge has already started to contribute to the narrowing of this canal. As we come down to the next level, we see the disc has also lost quite a bit of height. There's bulging, and then there's some ligamentum flavum. This black ligament has additionally pressed in, and it contributes to a drop of the diameter of the canal. You can see it's quite a bit different from here to here versus a here to here. This is the normal caliber of the canal. As we come down yet again, we see another disc, okay? It's lost height. And we see a bulge of the ligament. There's been settling. Disc bulge, ligament, contributing to a severe overall narrowing of the canal. We come down here to the L4-5 space. We see what we call listhesis, a little slip forward, not uncommon to see in folks. That also contributes to canal tightening. We see a big ligamentum flavum with a complete obliteration of the canal diameter. And so this patient, when I saw him, had been reduced to essentially walking barely to the mailbox and back at significant pain each trip. Couldn't walk the dog, couldn't play golf, couldn't do any of those things. And he's been rendered essentially dependent on a front wheel walker. He would have to sit after about 60 feet and then rest, and he could get up and go again. And so because of it, he's developed osteoporosis, he's developed cardiovascular disease, his overall body habitus has changed significantly. So this is what he presented with, this significant spinal stenosis. So this is the sagittal cut. What I'm gonna do is take you over to what is called the axial cut, and it correlates to the sagittal cut. So I'm gonna have you see both at first. So you can see here's a slice right like so through, and right here we see the canal. I'll get a better pointer. We see the canal, we see the spinal cord, that's the dark gray. The white is the cerebral spinal fluid around the canal. And right here at this cut, which is high, you can see this one's way up here. There's no encroachment on the canal whatsoever. It's open, and there's nothing pressing on the cord or the neural contents of the canal. Now, as I bring down this axial cut, you'll see that little scout line on the left descending, that purple line. You keep an eye on this canal, okay? You can see there's a little renal cyst, there's this aorta there, coming down, starting to get a little more narrow. And as we come to that first level of stenosis, you can see now that there's very little CSF. There's a little bit of cerebral spinal fluid here. Here's the terminal portion of the cord. The nerve roots are starting, but it's starting to encroach. You can see how tight it's getting. As we come down a little, again, follow this canal. Coming down here, you can see the canal's here. If we see light gray, that's cerebral spinal fluid. It opens up a little bit. It's wide, coming down, getting quite narrow here. And you can see at this next cut, slice right here, it's extremely narrow. This is epidural fat, okay? The canal is now sandwiched into this small space, and all that dark gray is essentially the lengthwise spaghettis of the nerve roots that are compressed together by the joint, the facet joint, and the disc bulge there. There's hardly any room at all. As we come down, as you recall, that's one of the least affected levels. We come down again, you can see starting to get narrow, extraordinarily narrow here. Again at L3-4, super narrow. Come back up, a little more widening there at L4 posteriorly, and at L5-S1, L4-5, near complete obliteration is what we call it, of the interthecal contents. There's simply no room for those nerves to get blood supply. And as we come back down here, you can see that it opens up. 5-1 is a normal segment. Now, there's an interesting finding. I've never really seen it or heard about it discussed in the neurosurgical or neurologic literature, but it's a finding that I'll reveal to you that is essentially a dead giveaway for symptomatology. If we see an MRI like this, almost always, if we see a loop or a curve within a distal nerve root, we know that there is tension, actually traction on the nerve roots that cause this additional redundant loop of nerve root. Whenever we see that, the patient has to have symptoms. It's one of those hallmarks. And of course, the patient does have symptoms. What does he say? He says, I can't walk. When I sit down, I feel a lot better. So that's how to read the MRI. And it's really important to be able to read this MRI because everything comes, all the options come based on the MRI. Let me explain why or what the thinking was behind the traditional laminectomy infusion. What was a laminectomy? What is it? So the lamina is essentially the roof of the canal. You can see it right here. Here's the lamina, here's the spinous process. This lamina provides the bony architecture that the muscles attach to, all the ligaments of the spine, but they also support and protect the canal from any injury. So the only option is previously surgically, and it does work. It's one of the few lumbar spine surgeries, one of about 3 that really do have a positive outcome. But the idea is to simply make an incision here in the bone, either remove this half of the joint or not, but take the roof off and decompress. Basically remove all of the mass effect from one side of the canal so those nerve roots can breathe. The problem is, as you can imagine, is we remove these spinous processes and we remove the lamina that support everything, then the stability of the spine suffers significantly. It's kind of like taking the laces out of a shoe. And as a result, over time, we found that hyperdynamic movement of the lumbar spine then was translated into increased wear at these discs, and these bony bodies would slide around on each other, and significant, if not severe, degeneration would then occur at a much more rapid rate. So thought and consideration was given to fusion. How do you stop that hypermobility? The only way to do it is to come in and then put a piece of bone or a spacer in the disc to further elevate the bones from each other and yet fuse them so there's no more movement. That required instrumentation. It required a pair of pedicle screws at each location, and then rods in order to secure those screws so that we could hold the substrate together so that it would fuse up. It's interesting, a lot of people think that the rods and screws are themselves what provides the structural support for the spine. That is not true. They are simply the scaffolding used to hold these bony vertebrae in place so that the fusion, the bony connection across, essentially just like you had two bones that had fractured or a fracture of a bone, they knit together with the fusion. And then once that occurs, the substrate, the strength of the spine is entirely within the bony column, not within the pedicle screws and the rods. So in Europe, many countries in Europe and Japan and Asia, many countries, we actually, they plan on a 2-part procedure. The rods and screws go in and then they're removed once the fusion takes place. So clearly taking the pressure off these nerves with a laminectomy is helpful. The problem is it's a big surgery. It's usually around a 3 to 5 hour surgery, depending on the number of levels. The recovery time in the hospital is 3 to 5 days, about a week. The data reveals that about 20% of patients, maybe a little more, 25% of patients have a complication. such as a dural tear, a cut, or an interruption of that fluid-filled sleeve that requires a very tenuous repair. Blood losses can be significant, infection, but the total complication rate of laminectomy and fusion in the literature is somewhere around 20, 25, even 27% in some studies. That's significant. Once you're out of the hospital, the recovery time to really get back to normal activities is around 2 to 5 months. If you're in the surgical realm, you've talked to neighbors and friends, you know that not everybody gets out with great success. So there's lots of room for improvement, as you can imagine. And that difference in high quality outcomes and complexity heralded an interest in minimally invasive approaches. And that's essentially where interventionists such as myself have enjoyed a real revolution in terms of the options available to us. That's going to be the next segment. What do we do? What other than the big surgery can we do for people who have severe disease in their spine, or even moderate disease? So that'll be our next phase. We're going to talk about what are the minimally invasive options for spinal stenosis that exist between frank laminectomy and epidurals and physical therapy. And we've, in the interim, developed something called interspinous spacing, which is probably the bulk of the treatments that are available. And I'm going to explain some of those and what those products are. There's also a couple other things. There's something called an ion facet screw, and also mild, minimally invasive lumbar decompression. And then there's also a host of other interspinous spacers, which are a little bit different, which are in the pipeline and currently being rolled out. So the first and probably the oldest is something called a Vertiflex interspinous spacer, a Superion interspinous spacer. It was the first of the bunch, and it was an attempt to provide a stabilization and instead of a resection of the ligamentum flavum, like we talked about during the laminectomy, it's actually a stabilization that props open the spine. The idea is that most folks are getting pain relief when they sit because of the change in the anatomy of the spine. Their lordosis or sway in the back gets less accentuated because their hips have moved forward. So the concept is to put in a little spacer to essentially hold the spine in the sitting position when one stands up and walks. And it preserves that space and allows the spine to move without the compression of the nerve, protecting the nerve from the sandwiching that occurs as we stand and walk. This is what it looks like, and you may see there's some other videos out there about it. I'll show it to you a little bit. It's a foldable, looks kind of like an X-wing, and these two wings, the brown wings, fold down, touching each other when we install it, and we simply place it into the interspinous space like so, thus holding the spine in the open position when we are standing and walking. Otherwise, what would happen is that there would be collapse, and we would simply sandwich and start to pinch that segment. So this holds the segment in extension, preventing that collapse when you walk. There's some caveats to this, and the main caveat to this is the way it was designed is it's thin, and the thinness, sadly, this portion right here, the thinness can erode into the bone over time. And one of the things that we didn't necessarily anticipate was how this would work over hundreds of thousands or millions of oscillations and repetitions. And so in about 50% of people, it seems to erode into the bone or have what we call subsidence, where the bone settles down around the implant, and then we get the spinal stenosis again. So that's the main concern with the Vertiflex interspinous spacer. But for a good, at least half of the portion of patients, it doesn't really do that, and it opens it enough that you really need nothing more. The secondary solution was built on the shoulders of that, and it's called a Minuteman. It's made by Spinal Simplicity, and it's another attempt to again hold open the interspinous space. You can see it looks kind of like a bolt. It's put in percutaneously from the side, locked in place with an expansion on this side. You can see it kind of looks like a drywall expansion bolt. The good thing about this is it largely obviates the spinal subsidence. It holds on to the spinous process on both sides, and it further stabilizes the spine. So there's minimal segmental motion, segmental movement, and wearing on the segment. It's an improvement, I think. Nevertheless, I still think there's some caveats. Both of these carry with it a small risk of spinal fracture. I think this one, since it sandwiches down on the spinous process, actually increases the risk of spinal fracture a small amount, maybe doubles it from about 2% to 4%. But that's the Minuteman Simplicity, Spinal Simplicity interspinous spacer. An improvement, I think. Next, an ion facet stabilizing screw. This is, you can see, is, and I'm doing this in reverse, it's a small screw that goes into the facet joint. You can see it right there. It's very tiny. It's placed percutaneously, and what we do is we place the patient on the table. We put him into lordosis, that means stretching of the spine and separation. And then as we hold him in that position on the table, we simply place these two little screws into the facet joints, fusing the facet joints in this open position, and thus opening up the foramen and opening up the canal so it remains open and patent. Again, another attempt to prove or hold the position of the spine when one stands and walks. Subsequent iterations of these devices are all going to be focused on moving the implant forward where it's stabilized without the lever arm of the spinous process, and maybe even adjustable over time. There are a few in the works that allow for percutaneous increase of the stretch or advancement that can be done in the office, for example. There are additionally some that focus on resection of the ligament. This is principally the mild approach. And what this works on is, if you can see the ligament inflavum, I'll show you on this MRI what I'm talking about. The ligament inflavum is this bulge of black that you see right here. And that bulge of black indents the thecal sac, and it's really, on this particular MRI, quite severe. And you can see over here on the cross-sectional one, that black ligament right here, if that can be resected, then you can see that there'd be quite a bit of opening of the canal and quite a bit of patency restored. The challenge of this particular approach is the following. It's mild, minimally invasive lumbar decompression, but it's also mild in that it's not an extreme procedure. And the ability to get deep within the spine safely is limited by that limit of safety. And so it's difficult because the way in which we go, we use fluoroscopic guidance. We can't see the ligament, we can't see the nerve roots, it's not MRI. We can simply go by feel and then also by the radiology itself. So I think it places a little increased risk for injury to nerve roots, possibly. I do this procedure while patients are awake so that they can talk to me through the procedure and tell me what they feel. I think that's a safer way to go. I don't think it's nearly as dangerous as an open spine surgery with multiple complications or a complication rate of around 25%. I think the complication mild is less than 1% still. But nevertheless, these kinds of complications are serious, and when they happen, and they happen to you, or if they happen to my patient, then it's a major deal. So that's the lay of the land for spinal stenosis presently. This is 2013, March. There's several things coming. There are a few other treatments that'll be pharmacologic implants or pharmacologic drug-eluting devices within the spinal canal, which will be coming that may help. There may be ways to open and secure with even more minimally invasive approaches. There may be ways to file down the anterior part of the facet joint so it has less mass effect on the canal, all percutaneously. Nevertheless, I think we've got great results from some of these approaches. I don't think they fit everybody, But nevertheless, the lay of the land is dramatically different than it was, say, just even 5 years ago, when just a few of these things existed. Lastly, I hope you've enjoyed this. I hope it's been illustrative, illustrated some of the things that are available. Thank you for your time and attention.